Welcome back, everyone. This is the last of the 8 lectures that I want to be giving on experimental designs. What I'd like to give you is an example of a randomized control study. It's somewhat old, but I think it has great teaching points that I'd like to raise. It was done by one of my colleagues and friends, Julie Buring, who is going to be talking to you also in this course about a current study they're doing. So you'll see Julie and learn more about her work at that time. But let me talk about a study that they completed a number of years ago. Basically, information about the Physician's Health Study is available on the web. And I suggest, if you have time, to go to their website and you'll find history and results of the Physician's Health Study. I'm just going to summarize some of them here. Basically, the Physician's Health Study wanted to address 2 questions about preventing chronic disease. One question was, is taking 325 milligrams of aspirin every other day reduce a person's risk of developing a death from cardiovascular disease? In addition to that, they wanted to ask an entirely different question, whether taking 50 milligrams of a different potential preventive agent, beta-carotene, could reduce your risk of developing cancer. So unlike many clinical trials, or in this case randomized control trials, prevention studies, they were trying to address 2 research questions with a single study, and I'll show you how they did that in a second. But the Physician's Health Study began in 1981. They sent invitations to enroll in the study, along with consent forms, to 261,000 male physicians living in the United States. Let me ask you, why do you think they limited their study to male physicians? Well, actually, not just any male physicians. The physicians had to be 40 to 84 years of old. They had to be living in the United States and registered with the American Medical Association. Registration allows them to get names and addresses, billing information, to send these letters, these packets, asking these American physicians between the ages of 40 and 84, would you be willing to be enrolled in our study? So again, why physicians and why men? Well, this again is the dark side of epidemiology. We have to root for people developing outcomes to see if one group has more outcomes, higher incidence, than another group. If the outcomes are bad, like death from cardiovascular disease or developing cancer, we want to enroll people who are at high risk for developing those outcomes. So unfortunately for myself and for others who might be watching me in this class, being a male puts me at high risk for developing mortality, dying from cardiovascular disease, and for developing some cancers. So it's better to enroll men in a randomized trial than females and women in a randomized trial if I want to enhance the number of outcomes I will see. The problem with this, at the end of the day, is I'm going to have a study with just men in it. I'm going to be able to answer the question whether aspirin is good for men, whether beta-carotene is good for men. I'm not going to have any information whatsoever about the effect of aspirin or the effect of beta-carotene for women because there are no women in my study. I have poor generalizability. But what I have is hopefully better internal validity because just having men in my study, if I get different outcomes among the aspirin users than among the non-aspirin users, I can't blame it on sex because all the aspirin users were men, all the non-aspirin users were men. So I have perhaps better internal validity, but worse generalization, worse external validity. But why physicians now? Why not just enroll any male between the ages of 40 and 84 living in the United States? Well, the answer is we want to measure outcomes, and we want to measure these outcomes in the male. Unlike the Framingham Heart Study, where people come back every 2 years to be further examined, Physician's Health Study was a male, M-A-I-L, meaning via the postal system in this country, to collect information about outcomes. And they were hoping that physicians are more likely to report and to know if they develop cardiovascular disease or if they develop cancer. So what we're hoping is to enroll a knowledgeable group that will know their outcomes and also would be more likely to report them. Again, in the mail, in the postal system, when we ask them questionnaires every 2 years, since the last time we've seen you or talked to you or mailed something to you, have you developed cancer? Have you developed any signs of cardiovascular disease? So that's why they limit their results to males and male physicians in this case. Now, here's the problem with generalizability. I gave you a slide like this before when I talked about eligible people versus recruited people and how you lose people in the process of enrollment. They were able to send letters of invitation to roughly 250,000 male physicians. Not everyone responded. About half of those people responded saying, yes, I'm willing to be in the responded about either being willing or not being willing in the study, and about half of those people said they'd be willing. But not everybody who was willing to, said they're willing to be in the study was eligible in the study. They wanted to look at people who were at risk for developing cardiovascular disease and at risk for developing cancer. Well, if you already have cardiovascular disease, you're no longer at risk for developing. You're still at risk of dying from it. If you already have cancer, you're not at risk of developing cancer. So they excluded about 26,000 people because they already had a history of cardiovascular disease or a history of cancer, or if you read down the bottom here, is that they were current users of either aspirin or beta-carotene. Remember, the investigators were going to flip coins and ask people either to take aspirin or not to take aspirin, take beta-carotene or not to take beta-carotene, and they didn't want to enroll people who were already taking aspirin. Those people might be less likely to agree to no longer be on their aspirin if randomized to the non-aspirin group. More importantly, they might continue to keep on taking their aspirin because it's not a prescription drug. You might be randomized to the group that's in the non-aspirin group, but if you're still popping this aspirin pill every day, because that's what you've been doing before this study began, at the end of the day in the Physicians' Health Study, we're going to compare people who were randomized to take aspirin, and hopefully took it, to people who are randomized not to take aspirin. But if a large percentage of those people are still taking aspirin on their own, we're going to have a compliance problem. We're going to end up comparing aspirin users to aspirin users. So they excluded those 26,000 people, essentially down to half of what they had before, who were willing and eligible to be in the study. Now they ended up only enrolling 2/3 of those. They also left out another 1/3 of their people who were eligible, willing to be in the study, but the investigators didn't want them. And why didn't they want them? They didn't want people who are less likely to comply with their assigned medication. You were going to be randomized, remember, to receive aspirin or not to receive aspirin. If you start taking aspirin and it causes some problems, some stomach discomfort, some minor bleeding, you might stop taking your aspirin that was randomly assigned to you. You might become a non-complier. It would be better to know up front, before the study begins, whether you're likely to end up taking your assigned treatment, whether you're likely to be a complier. It would be nice if I could identify the non-compliers before I randomize people and then exclude them from my study. And that's what the Physicians' Health Study did. They utilized something called a run-in phase to find out which of these 33,000 people who were willing and eligible to be in the study would likely to be compliers if they were enrolled in the study. And basically how that worked is they took these 33,000 people willing and eligible, and they, during a short period of time before the study began, they asked them to take this pill. They were given active aspirin to take. They're also given a placebo pill that looked like the pill they would have received if they received beta-carotene. So these people are taking aspirin, active aspirin, and after 18 weeks of this run-in phase, participants were sent a questionnaire asking about their compliance. Asking, now that you've done this for 18 weeks, you're getting used to having to pop a pill every day. And you don't know it, but this pill is active aspirin. It might be causing some complications for you. Are you still willing to be in this study? And about 1/3 of the people, 11,000, said, now that I've been in this trial period, I'm not interested in being in your study. If you kept those people in your study, chances are they would be the non-compliers. So the investigators identified these 11,000 people up front and said, thank you very much, but we're not going to keep you in our study. They only randomize the remaining 22,000 people. Those were the people who were randomized in this study. So what's the purpose of a run-in phase? The goal is to enhance compliance among people who ultimately end up being in your study. This is done prior to randomization. You're essentially testing people on their potential for taking their assigned medication. So you're looking at potentially randomized people, and you're giving them a drug at that time, and you're essentially trying to identify who are the non-compliers. You want to essentially exclude these non-compliers before randomization, because if they end up being in your study, those are the non-compliers, those are the people who are in those C's, those B and C cells in the previous analysis we talked about, the non-compliers that cause problems for us in the analysis that could introduce post-randomization bias into our study. So knowing up front whether a person's a complier or not is a very useful thing to know, and that's what these run-in phases are doing. Now, run-in phases are not feasible for many studies. If I'm looking at a trial of surgery versus radiation among cancer patients, I can't expose everybody ethically to surgery up front, a sham surgery, just to see if they're willing to tolerate a surgery or not. So only for certain types of trials is this run-in phase doable. At the end result, you're eliminating people, and whenever you eliminate people, you increase the potential of having poor generalizability. The people you end up in your randomized trial who are actually randomized could be entirely different from the original target population. So if I go back to that diagram I had, they had a target population of 261,000 male physicians in the United States. They only enrolled 22,000 of them, less than 10%. Any result that's reported is based on those 22,000. Do those measures of association, those conclusions we see in those 22,000 reflect what would have happened among all 261,000 physicians? I don't know. That's the problem with generalizability. But what we're doing is we're enhancing the internal validity of our study by trying to do away with people who are not likely to comply, only randomizing people, those who are likely. So the analysis we do on the 22,000 is hopefully a very valid analysis. We've enhanced internal validity. Whether it's generalized or not is another issue. So that was the enrollment phase of the study. Here's how the study worked. Remember, there were two treatments that were being assigned to people. You were randomized either to take aspirin or to take a placebo pill that looked like aspirin. And among all the aspirin users, you were further randomized to receive either beta-carotene or a placebo version of beta-carotene. And among the non-aspirin users, you were further randomized again to beta-carotene or no beta-carotene. This is an example of something called a factorial design, because essentially what we're doing in the study is answering two different research questions. One research question is, does aspirin prevent cardiovascular mortality? Let's suppose that's treatment option number one. People are being assigned either to take aspirin or to take a placebo. That's aspirin placebo. In addition, everyone's being assigned to receive either beta-carotene or a placebo version of beta-carotene. So everyone's taking two pills. You can compare everyone who received aspirin, A plus C people, versus everyone who received placebo, aspirin placebo, B plus D people, to answer the question, what's the advantage of aspirin for preventing cardiovascular disease? Knowing that roughly half of the aspirin users are taking beta-carotene and half of them are not. And half of the non-aspirin users are taking beta-carotene and half are not. On the same hand, we can look across the rows. We have A plus B people who are receiving beta-carotene and C plus D people who are receiving placebo version of beta-carotene. That's a comparison to answer the question, does beta-carotene prevent cancer? Knowing that half of the beta-carotene users are also taking aspirin and half of the non-beta-carotene users are also taking aspirin. It sounds almost too good to be true. In one data set, you're able to answer two research questions. That's what the factorial design is trying to do. Each subject in this study is undergoing two levels of randomization. One to determine whether he takes aspirin or not, and one to determine whether he takes beta-carotene or not. There are other examples which the same group has done to look at this design. They did something called a women's health study. following the physician self-study to look at multiple treatments, including aspirin for the treatment of heart disease, prevention of heart disease among women. So it has the potential to examine multiple hypotheses, multiple treatments from a single study. That's good. But what's the bad part about these factorial designs? What's the potential problem? The potential problem is one due to interaction among the two groups. Let's suppose aspirin does prevent heart disease. But let's suppose that somehow taking beta-carotene blocks that benefit. So if I go back to my design, where remember I'm comparing everybody who took aspirin, A plus C, versus everybody who received placebo, half of the aspirin users were also receiving beta-carotene, and half of the non-aspirin users were also receiving beta-carotene. Let's suppose receiving beta-carotene somehow blocks the benefit action that aspirin has for preventing heart disease, meaning half the people in the aspirin group are not going to be able to see the benefit of aspirin because half of them are taking beta-carotene and beta-carotene blocks that. So if the effect of one drug depends on the presence or absence of another drug in a factorial design, we have a problem. And that's the potential limitation of factorial designs, when the effect of one treatment depends on the presence or absence of another treatment. For example, as I just said, the effect of aspirin being modified somehow by whether you took beta-carotene or not. If so, we are decreasing the power of our study to answer the question, what's the benefit of aspirin? Because only half the aspirin users have the potential to show the benefit of the aspirin. We might think we have in our study 11,000 aspirin users, but half of them are really meaningless for us because they are not able to show the benefit of aspirin. That's the problem of a factorial design, and the investigators have to decide whether the benefit of the factorial design to look at two hypotheses outweighs this potential for problems. So you don't want to do a factorial study when you think one treatment might influence the effect of another treatment that's being studied. This is what these participants had to do. They got a pill packet every month. The white pill was either aspirin or placebo aspirin. The red or orange pill was either beta-carotene or placebo beta-carotene. Every day you took one pill. And every month you got a new package that tells you this is what you're taking in the order of pill taking for this month. These are their results. This is their table 1, looking at everybody who was receiving aspirin plus beta-carotene, aspirin without beta-carotene, etc. There are 4 groups of people: aspirin and beta-carotene, aspirin in the placebo version of beta-carotene, the placebo version of aspirin plus active beta-carotene, and placebo versions of both. And this shows various characteristics of those people. Their average age, 53.2 in one age group, 53.3 in the next, 53.2 in the next, 53.2 in the next. Almost identical. That's what randomization is going to buy for you. Similar distributions of where these doctors came from in terms of their locations in the country. Randomization balances that also. This goes on for a number of characteristics in terms of their medical histories. 11% in one of the groups had a history of hypertension, 11.8 in the other group, 12.4 in another group, 11.5 in the fourth group. Again, very, very balanced. That's what randomization buys you. And I can go line by line, but you'll get the message as I go through here that things are very well balanced. The groups I'm going to be comparing are very comparable because of randomization. So finally, what are the results? Well, in terms of aspirin, the Data Safety Monitoring Board, remember that outside board of experts, scientists, decided to stop the study early. In 1989, years ahead from when it was supposed to stop, they declared that this study has to stop for primarily ethical reasons. There was clear benefit in this study up to that date that aspirin was very useful. It was clearly decreasing the risk of developing a myocardial infarction. The aspirin users had much lower incidence of developing myocardial infarctions than non-aspirin placebo people. We have to get that message out. We have to no longer deprive the placebo aspirin users from the potential benefit of taking an aspirin. It can decrease your risk of having a myocardial infarction. This was not their primary outcome. Remember, their primary outcome was cardiovascular death. And another reason they stopped this study in '89, is they reported these doctors are just not dying. We expected by this time to see so many deaths among these male physicians in the United States, and they weren't seeing those deaths occurring. Clearly, the study would have had to go many, 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 many more years in the future to see if aspirin prevented cardiovascular mortality. But they couldn't ethically go many, many years into the future because they would be depriving the participants in the study primarily and the rest of the world of the knowledge that aspirin might prevent myocardial infarctions. There were too few strokes, too few deaths to answer any questions about the potential harmful effect of aspirin causing bleeding in the brain, or the potential benefit of aspirin decreasing the risk of cardiovascular mortality. So they stopped the study early. 7 years later, they stopped the second part of the study, the beta-carotene, because they were saying that there was no clear benefit for beta-carotene preventing aspirin. So why did I take this aspirin pill this morning and every day? Because my physician tells me to do so. Why does my physician tell me to do so? Because the Physicians' Health Study did this study some 15 years ago, or actually some 25 years ago. Well, that's an example of an experimental study. What we're going to have is a series of lectures done by my colleagues describing a current experimental study they're doing. So the next time you'll see me, I'll be introducing to you my friends and colleagues who are working on a study called VITAL, V-I-T-A-L, a study that's looking at the role of vitamin D in fish oils. I'll let them explain the background and the justification and describe how that study is being done. So we'll do that next time. See you then.